Critical Care Simplified. If you work in critical care, you may care for a patient whose circulation depends on a left ventricular assist device, or LVAD. These devices support patients with severe heart failure when the left ventricle can no longer meet the body's needs. In this video, we'll simplify what ICU nurses need to know, how LVADs work, what to monitor, which complications to catch early, and how to respond in emergencies. LVADs are not routine cardiac procedure support. They are considered for advanced refractory heart failure. Some patients receive an LVAD as a bridge to transplant, meaning the device supports them while they wait for a donor heart. Others receive it as destination therapy, meaning long-term mechanical support when transplant is not an option. Think of the LVAD system in 6 parts. The inflow cannula draws blood from the left ventricle into the pump. The pump moves blood forward. The outflow cannula returns blood to the aorta. The driveline exits the abdomen and connects the internal pump to the external controller. The controller monitors function and alarms. Batteries or wall power keep the device running. Most modern LVADs are continuous flow devices. They improve cardiac output and organ perfusion, but they may also create a weak or absent palpable pulse. That means traditional pulse checks and blood pressure methods can be unreliable. ICU assessment must shift toward mean arterial pressure by Doppler, device parameters, and signs of perfusion like mentation, urine output, skin color, and capillary refill. Trend the 4 major LVAD parameters: speed, flow, power, and pulsatility index. Speed is the pump setting. Flow estimates how much blood the pump is moving. Power reflects electrical energy used by the pump. Pulsatility index reflects the native heart's contribution. A rising power reading with steady speed and falling flow is especially concerning because it may suggest pump thrombosis. Start every shift with a structured LVAD safety routine. Inspect the driveline exit site for redness, drainage, bleeding, or dislodgement. Confirm controller and power connections. Review device parameters and trends, not just single numbers. Perform a focused physical exam, especially neurological status and perfusion. Then, document clearly and communicate changes during handoff. The big 4 complications are bleeding, thrombosis, infection, and device malfunction. Bleeding may be obvious, like melena, hematemesis, epistaxis, or hematuria, or occult with hypotension and falling hemoglobin. Thrombosis may show rising pallor, hemolysis, dark urine, or neurologic changes. Infection often starts at the driveline exit site. Malfunction may present with alarms, loss of device hum, or sudden deterioration. In an LVAD emergency, move quickly but systematically. Call for help and notify the LVAD or heart failure team early. Assess responsiveness and perfusion. Listen for the device hum and check controller, batteries, driveline, and power connections. Respond to alarms according to device protocol. If power loss or controller failure is suspected, prepare backup batteries or controller according to policy. Here is a critical LVAD point. No palpable pulse does not automatically mean cardiac arrest. For continuous flow devices, pulse checks may mislead you. Chest compressions are indicated only when there is clear evidence of no perfusion, such as unresponsiveness, no Doppler detectable MAP, and no other signs of circulation. Protect the driveline and coordinate with the team during resuscitation. After the crisis, close the loop. Document the event timeline, alarms, interventions, patient response, and communications. Debrief with the team. Identify protocol, equipment, or training gaps. LVAD care is technical, but safe outcomes depend on structured assessment, clear communication, and calm teamwork. Stay curious. Stay compassionate. Stay competent.